Okay, so thank you very much, Alison, for that wonderful presentation. I almost feel very humbled by that. I mean, I don't know what to say. Thank you very much. And thank you all for coming out to hear about NMD and what we're doing at NMD. So what I thought I'd do, I'll tell you a little bit of background about our company and what we're trying to achieve. I'll then sort of who we are. And then I'll speak about the science and the new therapies that we are developing. And then I'll end it off by speaking more specifically about the clinical trial we are conducting in Charcot-Marie-Tooth disease. In order to set the scene, I would like to just remind ourselves, though, that of the incredibly important role that skeletal muscle actually have for our overall health. Skeletal muscle, of course, is the type of muscle that we're using for conducting movements. So whether that be our hand control, whether that be breathing, whether it be speaking, whether it be eating, these are the types of muscle that we're using for movement. It is about 40 to 50% of the body mass that is composed of skeletal muscle. And of course, we all associate skeletal muscle with the ability to conduct movements. In addition to this, however, skeletal muscle, due to the very large volume it has, also have other important roles. Skeletal muscle is by far the tissue that is able to increase its metabolism to the highest level of any tissue we have. And it also is a very important tissue for storing metabolites and proteins that can be either used in the muscle per se or be released to circulation, so it can be used by other tissues as well. So it's a very important, let's say, reservoir for important constituents that we're using in many different types of tissue. It is also a tissue that is important in perhaps aspects of physiology that we're not necessarily thinking about so often. It plays a role in releasing a number of substances, that means signaling molecules, that go into the circulation and are transmitted to other types of organs. That could be the heart or it could be the kidney, where they play important roles in preserving health and function. And probably that is why exercise is so helpful, because the active muscle is releasing substances that actually trigger some of the benefits in other more distant tissues as well. So all in all, skeletal muscle plays many different roles, diverse roles, and they are very, very important to preserve the function of. And that perhaps is why we actually do know that preserving muscle strength is the best predictor of overall mortality and actually longevity as well. So it's very important that we preserve muscle mass. Okay. So, and perhaps that's also why we are seeing that skeletal muscle is involved in many different types of diseases, from the very rare diseases that you see there on the left to the very common and large indications such as age-related muscle weakness and also in type 2 diabetes, very large indications, from rare to very large. And on the right, you're seeing a number of different disease mechanisms that can be at play that we see across the different types of indications. So given this, the important role, the large volume of muscle we have in the human body, we at NMD are very sort of focused on what can we do to make sure that we can actually improve muscle from a therapeutic point of view. And there are very few treatments that actually focus in directly on skeletal muscle and improving muscle function. And that's what we want to do. So we're driven by a purpose in NMD to really find new ways to restore muscle function, to provide a path for patients to live better lives. That's essentially our purpose of NMD. And the main approach we're taking here is we are developing therapies, so we're developing drugs. The main program we have, our lead programs, are developing what we call inhibitors of an ion channel. It's called CLC1. It's unique, this ion channel, in that you only find it in skeletal muscle. We're developing small molecules that can inhibit this channel, so it's a tablet. The specific compound is called NMD 670. And so far, this compound has been qualified for clinical work, and we have been able to show in patients with myasthenia that we can improve muscle function in myasthenia gravis patients. And that shows us that the mechanism works in man. And now, of course, we're hoping to expand to other indications, including CMT. The company per se is based on academic work conducted at Aarhus University in Denmark. This is the second largest university in Denmark, and it's where I did my own PhD, and part of NMD is coming from my own PhD back in the day. It means there's been work within muscle biology and muscle physiology there for about 50 to 60 years. And given this background, we really have a very unique translational research platform available at NMD, where we're actually leveraging all of this historic academic work that we're now taking into the company. And that's probably why we have, a very strong, let's say, academic underpinning really supporting the company. At this stage, NMD 670, which is the lead compound, is in 3 phase 2 studies in myasthenia, in SMA, and also in Charcot-Marie-Tooth disease. We do also focus on other earlier stage programs in other indications, all within the rare neuromuscular disease space. That's really our main core focus here. We're 60 people, as you mentioned. Yeah, you did. Perfect. I would say I'm very impressed by every single one of them. They're very, very highly skilled. They're very motivated, very committed to actually developing new drugs for the market. And that's when, with the patient in mind, to really make sure that we can get new treatment options out there. Of course, that side of it as well, we're a private company. We're financed through investments from large investment funds such as Novo and Lundbeck and Roche. They have invested into our company, and that's how we are supplying all of the funds we need to conduct the clinical trials. Okay, so that was a bit of the background. Let's look a little bit more into the science of what we're doing at NMD, and specifically around the CLC1. So in order to get there, I'm just going to sort of speak on some very general points about how the motor system is actually constructed. And this is a very simple illustration where you have the central nervous system with the brain and the spinal cord, and then the peripheral nerves, and then, of course, the muscle at the more distal part. And in order to activate our muscle, that is mediated by electrical signals that we call action potentials. They arise in the brain, and then they travel down the spinal cord, and then they interface and move into the peripheral nervous system, and then they contact every single muscle fiber at what we call the neuromuscular junction. These electrical signals, or action potential, must be transmitted from the motor neuron into the muscle fibers and propagate along the muscle fiber length to basically command the muscle fibers to contract. So these are essential signals. The muscle fibers will not react unless these signals actually go through into the muscle fibers. And the way we then regulate, how intensely we activate our muscle is in 2 ways. We do it either by increasing the frequencies of these signals that comes down to the muscle fibers, so increasing the frequency of the blue signals basically, or we change the number of muscle fibers that the brain decides to activate. So we can increase the frequency or increase the number of muscle fibers that we use. This is the way we regulate the intensity of our contraction. So that's the way the system works. The whole system, motor neurons to muscle fiber, is an extremely plastic system. It is something that really adapts to the use that we impose on it. So if you train, you get larger muscle, you get better functioning muscle. If you're less active, you're inactive, you also have disuse atrophy. So unfortunately, in part of some of the diseases where you have neuromuscular transmission failure or other types of dysfunction, part of the atrophy is actually related to the difficulty of not using it, because it's hard to activate, so the muscle fibers respond by shrinking, so to speak, wasting. So it's very plastic, and that also has some positives and potentially also some negatives. The way these adaptation occurs is partly by the release of these substances I mentioned before, that the muscle is able to release a number of substances that acts back on the nerve and actually stimulates growth and health of the nerve. So it's very important we use the muscle. It's very important we have activity, that the muscle fibers are actually responding to what the nerve is commanding, so we can get release of these substances acting back on the system to keep functional integrity as well. So, and this is perhaps a bit speculation, but let me try this out a little bit here. But so this design we have of the motor system is a great way to really have fast transmission. The fast transmission being that the electrical signals can travel rapidly through the nerves and into the muscle fibers. This is a way that we can actually get rapid activation of our muscle fibers, so we can avoid that we fall, the way that we can move fast, and we have dexterity. This is a great system for fast activation. Remember, the motor neurons are sort of started in the spinal cord, and then they stretch all the way down to our feet. That means that the same cell can be about 1 meter long, if not longer. That's a way of really having fast signal transmission. It's like an electrical wire that goes all the way down to the feet. Very clever system. It does perhaps, though, come at a compromise. It comes at the compromise that the nerve becomes somewhat vulnerable, especially at the distal parts, because the nerve tip needs to be supplied by what is in the spinal cord. That's where the DNA is. That's where it needs to be transported all the way down to the feet. And perhaps this is why we're seeing that diseases that affects the motor neuron in particularly affects the more distal part of the system. That's maybe why we're seeing the feet and then the hands being affected in some of these diseases. This, let's say, vulnerability of the motor neuron does suggest that this is a sort of biological compromise between rapid activation and then having some challenges as well. And maybe this is why we're seeing motor neurons being affected in CMT, ALS, SMA, and a number of other diseases. So all in all, this system does come with the challenge that at the most distal part, the very end of the motor neuron, is where the nerve meets the muscle fiber, is an area where there's potential risk of having, let's say, dysfunctions. And this is at the neuromuscular junction. So having therapies that really can efficiently and safely improve on that neuromuscular junction to restore the activation at that connection point would be very helpful. And that is indeed what we are developing at NMD. We have discovered a new way to improve the connection between the nerve and the muscle fiber by enhancing this transmission at the neuromuscular junction, as we call it. So this is an illustration of the neuromuscular junction here, where you have the nerve ending meeting the muscle fiber, and the transmission occurs by the signal arriving at the nerve terminal, causing release of a substance called acetylcholine. These are the small green dots, abbreviated ACH, and they actually bind to proteins on the muscle fiber surface. They are acetylcholine receptors. These receptors will then open, and then they will carry an inward flux of ions that are positively charged. This is an excitation of the muscle fiber that basically makes that signal go through into the muscle fibers and make the muscle fiber react. So this is well known. This is the way the system actually works. But what also is present, and what we realized back in the academic work back in the day, is that there's a very large number of also chloride channels sitting also at this neuromuscular junction. And what they do is they also carry ions that go into the muscle fiber, but these are negatively charged. So now you have some positives and you have some negatives. And the negatives are fighting out against the positives, basically. And in some conditions, and with disease, these negatives can actually dominate too much, and it becomes impossible to activate the muscle fibers. So that's really the role of chloride channels. So what we found is that if you can inhibit CLC1, we can boost this system by increasing the effect of the excitation by preventing this chloride channels from exerting a dampening or a, let's say, electrical braking effect. I hope that sort of makes sense, but let me try to illustrate it. So here you have some of the diseases where we know the neuromuscular junction becomes compromised. That can either be because the nerve terminal is not working correctly, it's not releasing enough of the acetylcholine. There are some of the diseases where we know this occurs. Or it can be a postsynaptic disease where on the muscle fiber side you have too few receptors to react to the released acetylcholine. In both cases, there are too few of the positive signals, basically, to be activating the muscle fibers. And then now if you also include the CLC1 channels that are sitting there as a big electrical brake, preventing excitation, that becomes far too dominating, so you can't activate the muscle fibers because you've lost some of the positive currents, and the chloride channels are being too powerful. What we're doing then with our NMD 670 chloride channel inhibitor is that we're taking out some of that CLC1 function, and we can then boost the transmission at the junction. So that is basically the way it works. Let me try to illustrate it also here. So we have, at the top, we have a situation where there is compromised connection points between the nerve and the muscle fiber. And now the signals are not really getting transmitted. You can see that the 3 signals became only 1 or 2 signals. If we now block CLC1, we can make the signals go through, and you get a proper transmission of the electrical signals from the nerve to the muscle fiber. And that is basically the way that the approach is actually working. We have been testing this in a number of different preclinical models, a number of different animal models, and I'm not going to go through sort of all of that science. There's a lot of science behind all of this, but let me just give you a little bit of highlights here. These are some experiments where we have worked with 4 different animal models, the myasthenia gravis, which is an autoimmune disease affecting the neuromuscular junction. We also work with spinal muscular atrophy, Charcot-Marie-Tooth disease animal models, type 1 and type 2, and then also even sarcopenia, which is related to age-related muscle weakness. As you can see from the top panel, we are able to, in myasthenia animals, to see a fast recovery of muscle force. The traces on the left are contractile force, so imagine we measure how strong a muscle is. And then we can see that in myasthenia, the red trace, the trace is much smaller, showing that you actually have a compromised muscle function. But if we now, in the same animals, administer our compound, we can restore that contractile force, and we can get the force back, and the animals become stronger. That also improves their breathing, that's the middle panel, and we can improve their survival. So that's very strong data from the myasthenia. Then also in SMA, we can see that if we treat with CLC1 inhibition, we can improve running of the animals. We can also in CMT1 and CMT type 2, that's the middle panel at the bottom, we're seeing that the animals are becoming stronger if we treat both CMT1 and CMT2. And then also in aging, we're also seeing improvement in the muscle function. So these are all rapid effects, and the message I want to convey here is that the mechanism has been efficacious in all of the animals where we have identified that there is neuromuscular junction defects, really. That's been very clear. We have also seen, however, another really interesting part of this mechanism, and that is with repeated dosing, we're seeing not only the recovery of force, we're actually also seeing some long-term benefits of this type of therapy. And that is captured here in 3 different lines of experiments where we, with repeated dosing, are seeing that in what we call a nerve cross model, where imagine you have the nerve that's supplying the muscle fiber, you damage the nerve a little bit, and then you need to see that the nerve is reconnecting to the muscle fiber. So it's been damaged, and then the nerve is pulling back from the muscle fiber, and then it needs to reconnect to the muscle fiber. That reconnection of the nerve to the muscle is something we can stimulate with the CLC1. So we can actually improve the nerve-muscle connection, not only functionally, but also at the histological level. We can see that the nerve simply grows better back to the muscle if we use the CLC1 inhibitor. We also see that in Charcot-Marie-Tooth disease type 2, that's the middle panel, and also in musk myasthenia model. So 3 lines of evidence, all conducted blinded studies in animal models. We're seeing that we can improve the nerve-muscle connection also at the histological level. We can make the nerve grow back to the muscle fibers, essentially. So this is some of the preclinical data, some of the animal data. We've also conducted clinical trial where we have actually been able to show efficacy of this NMD 670, first in myasthenia gravis, and now we're also conducting a trial in Charcot-Marie-Tooth disease. But let me just take it to the trial we conducted in myasthenia to sort of show you some of the benefits we've seen with NMD 670. So this is a small clinical trial with myasthenia gravis patients. Myasthenia is an autoimmune disease where the nerve-muscle connection is compromised, and patients are weak, and they are struggling with connecting and activating the muscle fibers. We had 12 patients in the study. The patients were invited into the clinic on 3 days, and on each day we tested some functional tests in the morning, then we dosed the compound, and then we would monitor at 3 and 5 hours subsequent to the dosing. We had 2 different dose levels, 400 and 1200, and we were assessing what is known as the quantitative myasthenia gravis scale. Now, one thing with myasthenia, and maybe I'd like to learn from you as well with CMT, perhaps, that in the morning the MG patients are doing best, and then as the day progresses, they get progressively more and more tired. This is something that we see in myasthenia. I'd like to learn, of course, if this is also something you perhaps can, some people are nodding, so it's important to take that into consideration. Yeah. So what we see when we did this study in MG patients is that they were, when they were on placebo, they were getting gradually more and more tired during the day, and that's what you can see here on the first trace where the QMG was increasing. It doesn't matter so much what QMG actually is, it's just a functional test. They were getting worse during the day, and that was kind of expected from the placebo. However, when they were on treatment, the same individuals went the opposite way, that they were actually now improving, and we were able to, even with a single tablet, see both clinically meaningful and statistically significant benefits of this type of therapy. And what specifically we were seeing is that they were getting stronger hands, they were speaking more clearly, they were able to control their eye function better, and also that they actually we were able to see some improvements on EMG signals. But maybe more importantly, we're seeing distal muscles reacting, we're seeing bulbar muscles reacting, and we're seeing facial muscles reacting. So that's very good that we saw this. And we take this to really be, let's say, the first time that we can see that this mechanism of CLT1 inhibition is active in patients. So that was great. And now, of course, we want to go forward in other indications as well. So how do we go to CMT? Why are we convinced that we can do something in CMT? We have seen animal efficacy we saw efficacy in animal models. So we knew that the compound was going to be active, at least in the models. But that's very different from patients, of course. So what evidence did we actually have that there was reason to believe that our mechanism would work in CMT? The benefit of working with something at the interface between the nerve and the muscle, this neuromuscular junction, is that we can assess the function of that in the clinic. There are techniques whereby clinicians are able to assess how well does the connection point actually work. So we ran what we call a clinical observation study, similar to what is being done here during this conference actually, observations of performance and so on, and 6-minute walk test and so on. We did a similar thing, but we also included some EMG signals. And we included what is called the single fiber EMG. And it doesn't matter necessarily so much what it is, but it's a technique by which we can determine is the junction between the nerve and the muscle working well or not. We had CMT1 and CMT2 patients come into the clinic, and we determined the level of this neuromuscular junction defect and compared it to some of the functional capabilities of the patients. And what we could see is that in CMT patients, they are presenting with profound what is called jitter and profound block. What that means is you have some jitter just means that it's an unstable connection point between the nerve and the muscle, and blocking means that sometimes that signal just does not get into the muscle fiber. And that is what we actually observed. And importantly, I think we could see, and that's all the bolded number here in the table, is that we saw correlation between the level of instability of the junction, the jitter, and the blocking, between that and then the performance. So I'd like you to sort of take two things away from this, is neuromuscular junction defect is present in CMT. This is what this showed. And it also showed that that level of deficit at the junction correlates to functional capabilities. And that really creates hope that we, with a trial, could improve, hopefully, on things like ankle strength, balance, and walking. That's what we're hoping to see. So, and that leads me on to what are we actually doing in our clinical trial at the moment. It's a rather simple design clinical trial. It is a clinical trial where we have two groups, placebo or active. It is what we call a very early stage clinical trial that we need to learn about our mechanism in CMT, what endpoints are really responding, are there anything that we can see of positive effects that we should continue to pursue in a later clinical trial. We're inviting CMT1 and CMT2 patients to participate in this study, but we hope that this is a method that can be, or let's say, treatment approach that can be used to all CMT types over time, but we have to focus in initially. The study is active. It's being conducted in the US and also in Europe, and we currently have 36 out of 80 patients who are randomized, and we're still looking for participants in this study. 6-minute walk test is the primary, but we have a number of exploratory endpoints also in this, and secondary endpoints and exploratory endpoints. And the whole purpose of this trial is to test, does our mechanism actually provide benefit in CMT? And once we know that, we can run a subsequent study, a larger study, phase 3 study, for hopefully getting this to be leading to registration. So this, I'll just end up with an overview of the activities ongoing in NMD. We have 3 phase 2 studies ongoing. We have one in SMA, one I just spoke about in Charcot-Marie-Tooth disease, and also a larger study in myasthenia gravis, where we have several different dose levels as well included in that study. And then we're doing some earlier work as well on different animal models and also developing additional, let's say, product for our therapy. So with that, I'd just like to thank you for your attention, and that's exactly the offsite that Alison actually came to visit. So, so thanks a lot for your attention.